right, let's jump right in. Today we're doing a really high-yield, consultant-level deep dive into how we manage developmental dysplasia of the hip, or DDH. And we're going to tackle this exactly like you would in a Viva exam, focused on logic, the key decision points, and a structure that just makes sense. Okay, let's get into it. Okay, picture this. You're in the hot seat, and they hit you at this classic scenario, a 9-month-old dislocated hip. The clock's ticking. Before you even start talking about specific surgeries, you need a framework, a logical structure that shows the examiner you get the big picture. So where on earth do you start? You start right here. This is it. This is the single most important principle, the absolute golden rule that underpins everything else. The management of DDH is an algorithm, plain and simple. And the main thing that decides which path you go down is the child's age when they show up. Nail this one concept and the rest of your answer will just fall into place. So, here's our game plan. First, we'll build out that core treatment algorithm. Then, we'll break down management into 2 critical chunks, the first 18 months, and then what to do with a walking child. After that, we're going to open up the osteotomy toolbox, look at some of the really interesting debates happening right now, and then wrap it all up with a high-yield summary to lock it all in. Okay, Section 1, the treatment algorithm. I want you to think of this as the master blueprint. This is the foundational roadmap for your entire approach, and getting this structure clear in your head is absolutely essential. So real quick, let's just define what we're talking about. DDH isn't just one thing, it's a whole spectrum. It can range from a socket that's just a little bit shallow, that's the dysplasia part, all the way to a hip that's kind of slipping out, which is subluxation, or one that's completely out of the joint, a full dislocation. And our job really is to get that hip stable and centered so it can develop normally. And boom, here it is. This table is your best friend. This lays out that core concept perfectly. Just look at the pattern. You see that clear escalation of treatment as the child gets older, right? From birth to 6 months, we start with the simplest thing, the Paediatric harness. If that doesn't work, or for kids a bit older, say 6 to 18 months, we step it up to a closed reduction. Then, once you get to a walking child over 18 months, open reduction becomes the main event, often with some bony work thrown in. This progression, based on age, is the anchor for everything we're about to discuss. Okay, let's zoom in on that first group. Section 2, management in the first 18 months. This is really our golden window of opportunity. It's when we can harness the body's incredible potential for growth and remodeling, and hopefully avoid any big surgery. Now, the Paediatric harness is pretty clever. It's not a rigid brace that forces the hip into place, it's dynamic. The front straps keep the hips flexed up, and the back straps stop the legs from coming together. This position gently points the head of the femur right at the socket, and then the baby's own kicking and wiggling does the rest, encouraging that socket to deepen all on its own. It's the gold standard for a reason in those first 6 months. So you've given the harness a good go for a few weeks, but the ultrasound shows that the hip just isn't sitting where it's supposed to. This is a huge pivot point. Why? Why isn't it working? What's physically stopping that hip from going back in? And this right here, this is pure exam gold. You need to have this list ready. These are the classic anatomical blocks to reduction. Sometimes the soft cartilage labrum gets flipped into the joint, or you could have a big, thick ligamentum teres in the way. Sometimes fatty tissue called a pulvinar fills up the socket, and the iliopsoas tendon can even create this hourglass-like squeeze on the capsule, pushing the hip out. Knowing these potential blockers is key to understanding why you have to move to the next step. So whether the harness has failed or the child is just older to begin with, in that 6 to 18-month window, your next move is a closed reduction and spica cast. This means we take the child to the operating room, and under anesthesia, we gently maneuver the hip back into the socket. We'll often confirm it's in a good spot with an arthrogram, where we inject dye into the joint to see the cartilage, and then we lock it all in place with a big body cast. Okay, let's shift gears now. Section 3, management of the walking child. Now we're dealing with a totally different situation. The hip has been out for longer, the body's anatomy has started to change and adapt, and that window for easy natural remodeling, well, it's closing fast. This really shows the massive shift in our whole philosophy. You see, with an infant, we're basically a guide. We're just nudging nature along, putting the hip in the right neighborhood, and letting the body do the hard work of remodeling. But in a walking child, the deformities are already set in stone. The socket's shallow, the femur might be twisted. We can't just guide anymore. We have to actively go in and surgically fix the anatomy. It's a total switch from non-operative to operative thinking. And this is what that looks like. It's pretty dramatic. Take a look at this case, a 25-month-old. On the left, you see that left hip is riding way up high, completely dislocated. And then on the right, That's the result after an open reduction and a Pemberton osteotomy. That's where we surgically reshape that shallow socket. It's just a fantastic example of how we can really reconstruct the hip's anatomy in these kids who present late. Which brings us perfectly to Section 4, the osteotomy toolbox. Because sometimes just putting the hip back in isn't enough to make it stable. We have to address the bony problem itself. And this is where we, as surgeons, open our toolbox to literally reshape the hip. Now, this table is incredibly high yield. You'll want to sear this one into your brain for exams. These are the real workhorses. But notice the key thing here, the main dividing line, the triradiate cartilage. That's the Y-shaped growth plate in the socket. The Salter, Pemberton, and Dega all need that growth plate to be open, so they're for younger kids. The PAO, on the other hand, is for older, skeletally mature patients where that growth plate has already closed. And crucially, some of these redirect the socket, while others actually reshape it. So let's just make sure that concept is crystal clear, because it's a really important distinction. The redirectional ones, like a Salter, involve a complete cut through the bone. You are physically moving the entire socket to a new, better address. In contrast, the reshaping ones, like a Pemberton, use an incomplete cut. They hinge on that flexible growth plate, which lets you actually bend the bone to change the socket's shape and make it deeper. All right, now for the really juicy stuff. Section 5, debates and controversies. To really nail your answer, you have to show you understand that not everything is black and white. So let's talk about some of the nuanced consultant-level discussions that are going on right now. So a huge point of debate is what to do with that 6 to 24-month-old. Our algorithm says a closed reduction is the primary treatment. But what if it's a really high dislocation? Should you just skip the closed attempt and go straight to an open reduction? Is that less invasive first step really worth the risk if it might not work? And we actually have some hard data on this. This chart from a big meta-analysis is pretty telling. It shows that if you start with a closed reduction in these late-presenting kids, you have an almost 50% higher risk of needing another major surgery down the line compared to just doing an open reduction from the start. So yeah, open reduction is a bigger deal up front, but it might just fix the problem for good. It's a really important conversation to have. Here's another debate, this time going all the way back to the public harness. How much do you trust your hands versus the ultrasound machine? This quote from a big international study really shows the split. You have some experts who say the clinical exam is everything, and then you have others, like this one, who basically say, nope, I'm not convinced until I see it on the ultrasound. And I love this one. What about weaning a kid off the harness? Gradually reducing the time they wear it? It's super common practice. But listen to this expert's honesty. I do it, but not based on any data, just anecdotal. They're basically admitting we do it because it feels right, maybe because it helps the family psychologically. It just goes to show how much we still have to learn. Okay, let's bring it all home. Section 6, the high-yield summary. Imagine you're back in that exam room. This is how you pull all these threads together into one clear final answer. So what are the absolute must-know take-home points? Number 1, treatment is all about the patient's age. Number 2, management always escalates, from a simple splint to closed reduction to complex open surgery. And number 3, the goal is always the same, a stable, centered hip that can grow normally. But the field is always moving forward, which leaves us with one final thought. As our imaging gets better with things like 3D modeling and our understanding of the hip deepens, how is this age-based algorithm, our foundational roadmap, going to change over the next 10 years? That's the question that's going to drive the future.